So good evening, and Dr. Torrens, congratulations. Very well deserved. I'm Bill Barcellona. I work for CAPG, which is no longer the California Association of Physician Groups. We shortened our name to just CAPG a few years ago and embarked on national expansion. And we're now in over 40 states. We still haven't figured out a new name. So we just go by CAPG, and we joke that it stands for nothing. But actually what it stands for is this transition from a fee-for-service model to a value-based payment model. And we started advocating for this in Washington, D.C. back in 2006, 2007. Don Crane, Jay Cohen from Monarch Healthcare out in Irvine, and myself went back, and we had a lobbying firm in D.C. And we told our lobbyists, hey, we want to go talk to the CMS officials and the legislators in the Congress about how to transform American healthcare from a fee-for-service model to a value-based model. And we want capitation. And so they marched us over to the Avalier consulting firm, very fine people, all former congressional budget office officials and CMS and HHS officials. And we sat down, and the nice gentleman started laughing at us. And they said, don't you know, capitation is a dead payment program. It died 10 years ago. We were looking around. No, we're here. We have 150 organizations in California that thrive on capitated payment. And what a journey it's been since 2006 to go through the Schwarzenegger program here in Sacramento, to try to pass ABX1, to bring a universal healthcare system to California, the way that Governor Romney had in Massachusetts, to fail at the very last minute, but then to see it immediately picked up in Washington, D.C. in 2008 with the new administration, to see it go through all its gyrations in 2009, almost die within 2 weeks, and then pass in early 2010. And here we are in a regulatory paradise of implementation and transformation, which will keep us all employed for the rest of our lives. So it's really challenging at times, and I know for all of you in the healthcare organizations, especially the ones in CAPG that I work with every day, it is tremendously challenging right now. I've never seen the pace of change this fast. I've never seen it have been this disruptive, but it has never been this important either. We have reached a plateau in terms of what we can spend in this society on healthcare. And we spend so much. We have to drive better value for what we are spending, because it is eating into our children and grandchildren's futures in other areas, especially education, and especially in the social side of our society. And so kudos to CMS for cracking the whip on the healthcare system, when a Congress has been reluctant to continue the work of the Affordable Care Act since it was passed. And really, CMS has carried the torch on moving the Affordable Care Act forward, as have some of the state health exchanges, particularly covered California, and particularly our Department of Healthcare Services here in Sacramento with our Medi-Cal program. So what we see in the CAPG groups is this tremendous transformation now. Now, for some of us, it can't come fast enough, and it isn't far enough. And in some ways, the entire transformation under the Affordable Care Act, especially with the ACO model, has been, in a sense, a step backwards for us in California. We are a bit further ahead. We would like to see Medicare move to percentage of premium capitation models as quickly as possible, especially on the ACO side. That is going to take a lot of time. What I've learned, though, if I can go backward in my slide, when we meet with physician groups in all these other states, they are still on a fee-for-service system. They're still trying to figure out how to move into the elementary stages of capitated payment, how to mesh that with an accountable performance measurement system on the back end to achieve a value-based payment model. And it takes time. It takes a lot of regulation at the state level. It takes a lot of funding from the feds. It is going to be at least a 10-year journey. So as my colleagues have presented to you thus far, there is a lot that we don't yet know about where the value-based payment model will go. We're waiting to see how some of these pending regulations develop here over the next few months. There is also a very important regulation that should come out in May that aligns standardization of payment models and quality measurement between Medicaid, Medicare Advantage, and the federally run exchanges. And we're looking forward to seeing that 600-page monster come out in May. Because it gives me an opportunity to write more reports. But the APM and the MIPS, we do have a lot of questions right now. As we look from an organizational perspective, capitated physician group perspective, we're looking at who will the APMs actually be? Will our groups that are capitated today qualify as APMs? Possibly not. Can we get the 5% bonus after investing all the time and trouble? What is financial risk? And how do we figure out these risk thresholds? These are difficult questions for us in California with 30 years of experience in these models. They have really got to be daunting in states that have never even dealt with a risk-based payment model at all and have no regulatory structure to support it. On the MIPS side, just the transition at the individual physician level and small group practice level to actually bring in more use of performance measurement and tie that to a larger percentage of the physician's reimbursement will be a very, very difficult transition. We're looking at an ACO benchmarking rule coming out here, and we had to hire Milliman to come and explain it to us a few weeks ago. We did a 1-hour webinar. Some of you might have even attended it. I kind of lost interest after the first 3 minutes, but it's coming along nicely. The MSSP ACOs, when we first saw the ACO provisions in a draft of the Affordable Care Act in 2009, Don and Jay and I were emailing each other at like 11 o'clock at night. So excited about this section 3200 in the Affordable Care Act. Reading this and saying, hey, this is us. This is what we do. It was validation. Well, it didn't quite turn out that way, but it is a really important step forward to see how this evolution of the ACO now into its second generation, how it can continue to build on this notion of bringing all these different silos in a county or a region together to cooperate in the delivery of healthcare. It's a tough, tough undertaking, and it will take some time. And we'll have to crank through 2 or 3 generations of rules to get there. The next gen ACOs, also very promising for us. We're looking at it. We're finding some problems as we analyze the current state of where we think the rules are going to go. There are some tremendous potential downside risk for independent physician organizations. The current state of where the rules are going really tends to favor integrated delivery systems, and I think that's a characteristic of the fact that that's really what you find across the United States. Large hospital systems that employ doctors, that create an integrated delivery model that is based on fee-for-service, and the models tend to favor that. We are still a little bit different in California, and it's still going to be a little bit tougher to shoehorn our model of practice into these rules. In Medicare Advantage, which has always been, I think, the primary area of interest for our CAPG member groups in California, and really what I feel is our most advanced delivery model in California and the thing we can be most proud of. We're working very hard right now in Washington, D.C. to make sure that the future of Medicare Advantage develops such that providers across the United States can be transitioned into capitated models that incent them to innovate, to be more efficient. And these are some of the areas that we're really pushing in our three-prong platform for the Congress. And we've been very, very happy recently because we did see some effort in the congressional delegation, a bipartisan effort to support the use of alternative payment models in Medicare Advantage. And it's amazing to see that kind of bipartisan support for this transition. So I'll end it here, and I think we're going to move to Q&A at this point. Is that right, Ava? All right, thank you.